So radiopedia, if you're just typing in like, I just want to see an x-ray, you're going to get all kinds of stuff, right? So try to be as specific as you can when you're doing radiopedia. So far we've covered like 2 or 3 different things, right? After we get through today, you're going to have a couple of different arthritises, osteoporosis, things like that that you can start looking up and seeing what it looks like. If you're going to search radiopedia for stuff, be specific in your abnormality. Psoriatic arthritis, put that in the search bar. Osteoporosis, lumbar spine, put that in the search bar as you're kind of going through and studying this stuff. What would be really beneficial too is just normal shoulder x-ray, right? Just get used to seeing normal knee x-ray, because the more normal you see, the better you'll see the abnormal. What's nice about radiopedia too, I have these slides in here, but you can also do normal knee x-ray annotated. And it will pull up x-rays that are overlapped with anatomy labeled on it. So it kind of helps you, like, am I looking at the right thing? Oh, that's the fibular head. Oh, that's the patella. Oh, that's this condyle, that kind of thing. So if you add annotated at the end of your normal x-ray, whatever body part, radiopedia will pull up a labeled x-ray for you to help you understand where everything's at when you're kind of studying and seeing what's going on with that. But when you're looking for abnormalities, if you just put x-ray, thousands and thousands of findings. The percent on some of those cases, that's more of a percent completion and verification of like the whole study that they do, because if you can read about what happened to the patient, what the injury is, that kind of thing. You don't have to hang your hat on that so much or whether or not the picture is good. That's not a percent of the picture being validated, right? So if you search, when we learn about it, Bankart lesion, which is going to be a glenoid fossa fracture, right? It'll pull up those Bankart lesions for you. So be specific when you're searching radiopedia. Questions on that or any other challenges those who have already kind of attempted it have had besides what I just explained? Okay, so we covered focal and diffuse increases in bone density. Now we're going to cover some generalized decreases in bone density, osteoporosis, hyperparathyroidism, and the rickets and osteomalacia. So this one now, the hyperparathyroidism is not testable, but you're going to see it next semester in endo, and images can help you with that. So let's start with osteoporosis. Here's the big pathophysiology slide, okay? Hypogonadism is the most common cause, usually due to menopause. 2/2 means secondary. So that's medical shorthand for secondary, 2/2, all right, to hormonal changes, or orchiectomy. We talk about this being a female, more commonly a female disorder, a female disease, the osteoporosis. But if you have a male, for whatever reason, that had an orchiectomy, testicular cancer, whatever the case is, they are just as prone to osteoporosis as postmenopausal females, because it throws off that testosterone-estrogen balance. Right? Even females have some testosterone in them, but it throws off that balance, which can help them end up leading to osteoporosis. What ends up happening is you have a couple of things. You could have overactivity of the osteoclast, so too much bone reabsorption, right? Or really what it ends up being is the age-related loss with the hormones is the decrease of the osteoblast activity. It's not creating as much bone as it used to when the patients were younger in life, okay? Your trabecular bone turnover is more rapid, and we typically see it in the spine and pelvis. Okay, spine and pelvis. When I say pelvis, sometimes in the pelvis, a little hip area, that kind of thing. A lot of patients are asymptomatic. This doesn't typically cause a lot of pain. They are asymptomatic, right? Until they fracture something because their bones are weak, because they have a lack of density. They fracture a hip. They fracture a vertebrae or something like that. That causes pain, but the osteoporosis itself is usually asymptomatic. How do we find it? X-ray is often noted first. Why? Somebody comes in with back pain, we order the X-ray, we look at it, we go, oh, that's not what it's supposed to look like, right? You might have osteoporosis. Your DEXA scan, this is where we get the DEXA, the dual energy X-ray absorptiometries. Okay, English is hard. DEXA scan is your study of choice. What a DEXA scan is, it's a very, party time again. It's a very poor X-ray, right? What the DEXA does is it scans the lumbar spine and it scans part of one of the patient's hips, usually their non-dominant one, okay? And and it's looking at the density of the bone. It's not looking for fractures. It's a really fuzzy kind of picture, and you can't really read or dictate it that well, but what it does is it spits out a number, and it averages the density of the bone compared to a healthy patient of similar age, sex, race, and all of those factors. So those are important. And then it tells you whether or not they have decreased or increased bone density. What is going on? Good. I know. Somebody's excited. Yeah, party. Anyways, we'll try to work through it. But the DEXA is a study of choice. That's what actually can diagnose you with osteoporosis. Because there's a certain score cutoff. I'm not going to go over it here. You're going to learn about that later. That kind of hits, and when you hit a certain number, it's osteoporosis versus osteopenia. Osteopenia is it's not normal, but you're not at osteoporosis yet. You're in that in-between stage. It's kind of like healthy pre-diabetes, diabetes. Same kind of concept with this. Healthy osteopenia, osteoporosis, right? You can't decide between osteopenia and osteoporosis on x-ray. You really can't, right? We don't diagnose osteopenia from x-ray. We can have suspicion of osteoporosis based off of x-ray. This is why grandma gets shorter when she gets older, right? This is what happens. This will hopefully happen to all of us. That means we live long, healthy, good lives, and we are old enough now to where we're starting to lose that bone density because we have gotten older. The trabecular pattern is starting to widen, like in those first pictures we saw in the slideshow, and the constant weight of us and gravity walking around, it hurts. So what happens when it hurts? We lean forward, it doesn't hurt as much, I'm not putting as much weight on my spine, and so we do this, and then we start hunching over, and grandma and grandpa get that hunchback, right? It's most likely due to osteoporosis as we get older. This is why we get shorter. On top of that, our intervertebral discs start getting smaller too, again, from years of gravity kind of pushing down on that. And so that sometimes can be what they look like. All right, so here I am talking about spines and pelvis, and then I put up a foot x-ray, right? This just goes to show you that you don't need the spine and the pelvis to suspect osteoporosis. So what are we looking at here? So again, the one on your left is normal, okay? This is a normal x-ray. This is abnormal. So what do I see here? The biggest thing I see is I am going to be comparing my medullary trabecular pattern, comparing those two. Look at the difference in density. Look at how much more radiolucent the abnormal, the osteoporotic patient is, okay? Right? I can make out a decent amount of some like density sitting in there from looking at the normal, and then when I go to my osteoporotic one, it almost looks like a darker kind of black, almost like it's air going through there. It's not quite that, right? Because there is bone there, but there's not as much because that trabecular pattern is degrading, making more space in between the bone, right? So therefore it's becoming darker or more radiolucent than it did if we were healthy. That's kind of what's going on there. Now, is that cortex bright or white? Is there something going on? Are we having increased activity there? Maybe. Or it also could be the fact that because of the radiodensity differences and how radiolucent the medullary bone is, it's making that pop just a little bit more. It's like putting things next to each other, right? So, but this is your sign. It's more inside the bone. And we'll see some more pictures of this primarily in the spine kind of as we go forward. And I think that is, yes, that is next, okay? Look at your normal and your abnormal. The first one on the far left is normal. Yes, sir?
Was that foot, is that the inferior view?
So that is actually what's called, it is still called an AP foot, but it's shot from the top down to the bottom. Right? So when you shoot a foot, it's like their foot is sitting here and it's just coming down on the top and the plate is underneath the foot.
Okay, so the R was backwards, so.
Yes, why was the R backwards, right? The R is backwards just because depending on the position they have, maybe that's just kind of came across and they had to flip it. That's why I talk about how the text is always going to flip it to the way that you need to see it. So sometimes they may have shot it in a direction or in a way that the R was the other way, but then they've flipped it 180 so it looks like the way it's supposed to. So just know that's right or left, that won't really kind of affect, it's always gonna look this way for you. Okay, so look at my spine, all right, look at my normal. And this is where comparing normal to abnormal is gonna help you when you're looking at stuff. I want you to see a couple of things. One, the first thing I wanna see is I wanna see these nice, beautiful, shaped, straight vertebrae. Okay, that's step one. Two, my densities all kind of look the same inside my vertebrae. And this nice kind of grayish, smooth area when I'm taking a look at them. Now when I come over to my abnormal, I'm starting to see some compression. We'll talk about compression fractures a little bit later. These guys are not as robust as some of the other ones. I'm also starting to get these little kind of like osteophytes hanging off the front there, of the front of the vertebrae. And then look at my density of how dark it is in here compared to here. I do the circle so it's easier to kind of look at the two and see the density difference. Most of the time with your lumbar spine x-rays, this is how you're finding osteoporosis if the patient doesn't know they have it. This patient came in with back pain. The back pain is likely due to these compression fractures, and we'll see more compression fractures in this block, right? Where the vertebrae is basically getting smushed down. It's having a lack of density from the osteoporosis, so from the weight, it gets smushed, it gets compressed. So it's a compression fracture, and that causes some pain. You get the x-ray, and you can see how much darker it is compared to my normal lumbar spine. Right? If I were to give you, before talking about this, just this one, right? Hey, tell me it's osteoporotic, you guys wouldn't be there, right? But when I give you the normal right next to it, looking at normal, knowing what normal is supposed to look like helps you make abnormal kind of stand out. Couple other things going on in this x-ray, right? So, we got that right there. That's a calcified aorta. Seen commonly in older patients, her aorta is starting to calcify. That's why we can see that. We normally can't see the aorta on an x-ray. But if it's calcified, it may stand out. So that's what that is right here, is a calcified aorta. All right, and then, yeah, so another one right here, another calcified aorta. That's what that is on that x-ray. But another hallmark sign of those compression fractures and osteoporosis is going to be those osteophytes that are kind of on the front edge of the body of the vertebrae. So we're going to see those extra little kind of bone growths, we'll call it.
Is that not the same x-rays?
It is, it's just more magnified. Yeah, it's flipped and more magnified to make the osteophytes kind of stand out. The two in the middle are the same x-ray. Questions on these films and seeing those abnormalities? Okay, so how do we go through some of this stuff, right? Imaging is adjunct. Read the question, read the answers, then what other information do you have that can help you? The imaging is helpful, so is the patient presentation and the history. Is it a postmenopausal woman? If it's a 23-year-old male or female, osteoporosis probably not on my differential, right? It's possible, but probably really rare. But if it's a 72-year-old female, now I know this is a possibility that fits the patient demographic, postmenopausal female. So you'll use all of those pieces of information to help you try to get to what's the most likely diagnosis or the most likely abnormality based off of where we're at. All right, questions on osteoporosis for now? If you think of it, let me know. Hyperparathyroidism, we'll breeze through it pretty quick just so you've seen it before, but basically it's just what it says, overactive parathyroid glands, you get too much parathyroid hormone, and you end up getting an issue with the bone metabolism, okay? Your symptoms and signs are related to your serum calcium levels, all right? Which means a lot of times you're asymptomatic, but what's high? Your calcium is high. So your hypercalcemia patients, in most cases, are going to be your kind of your clue when you get these X-rays. You look at the labs, right? Usually we can get an X-ray with a complaint. This stuff is an incidental finding. People don't come in because their bones hurt from hyperparathyroidism. They come in for other reasons. You see the abnormality on the X-ray. Maybe you weren't tracking for hyperparathyroidism, turned off. There we go. But then you start to see something like this, and it makes you go, okay, I ordered a hand x-ray because your hand was bothering you. Why the heck are you missing parts of your phalange sitting in there, your middle phalanx? Okay? So what happens is you get a decrease in the bone density, you get some bone reabsorption, particularly on the radial side of the middle phalanx. Why does it attack right here? It's just how it does, right? One patient dies in 6 years, one. I found hyperparathyroidism on a patient one time, this way. Why? Because I saw the x-ray, thought that was weird. Hey, did you ever have any damage or injury to your hands? No, I haven't. Let me go ahead and order some serum labs on you. Calcium was through the roof, and then did some more digging, which I learned about in endo, found out her parathyroid hormone was going crazy. Turns out she's been having other symptoms that she wasn't even coming in for at the time. She was coming in for hand pain, just dealt with the other stuff, assumed, she was like 43, I think. So it was assumed all the other symptoms she was having was like just perimenopausal stuff. Oh, women go through changes. So she didn't bother coming to see a doctor. She had hyperparathyroidism. So, what as I say, one patient in 6 years of practicing medicine before I came here, it's not very common. But that made a difference in her just because I was like, oh, let me go and order labs. So that's kind of what happens there. You'll see this again in endo. That's all I need. Again, not going to test you on it, but that could happen to you someday. So, rickets. Notice her pathophys eye patch student is not on there. From the other day. Close, but no. Really, rickets is a vitamin D disorder, right? Most common cause is nutritional, Asia and the Middle East. We go there? Yeah, they're usually pretty frequently, right? So you'll probably see this at some point. Asia and the Middle East, it's usually vitamin D dependent. Most commonly in young kids, they have a bow-legged appearance. X-ray is your initial study. I'll get this question too. I have initial study on here. I don't have anything in blue. That means X-ray is both, right? There's no other better study. If I don't have a blue on here, like some of them, I was like, X-ray is initial, MRI is study of choice, or DEXA is study of choice. If there isn't a study of choice on the slide, then it's X-ray. Like that's how we diagnose it. That's what we use for it. What are we going to see with this? We're going to see the bow-leggedness. We're also going to see cupping or scalloping of metaphyses and fraying at the tips of metaphyses. So this is kind of what it looks like. Bless you. Again, pediatric disorder typically, I will fully admit that the scalloping on the inner part of the cortex is a subtle finding, right? But take a look at my cortex, it's a little magnified, and how like I come down smooth on the outside, I go to the inside, and I have like this scalloping there. If I come on this side, maybe a little bit there, and it kind of comes down. So that's one side. And what you're going to see more often is this fraying of the distal tibia and the distal fibula, distal femur and fibula too. Whereas look at my normal. This is normal, right? I can make out that cortex pretty well on both the femur, the tibia, and the fibula. That nice, bright, whitish line is really clear on that kid. But when I come over here, where's my cortex? I can't really tell. It's got this fraying at the ends of those bones from the lack of vitamin D in the rickets. Another sign is the bow-leggedness right here. Okay? The way the femur kind of bows out. Now here's the catch with this. You need some patient history. Don't get an x-ray and see somebody with bow femur or bow tib fibs and go, you got rickets. You're not giving your kid vitamin D. Right? Especially if you're here in America. Because depending on when they started to walk, they may end up with some bow-leggedness, particularly in the tibia, because you only walk around 1 year old, right? 1 year, a little bit later than that. There are some kids, like especially when they're like the second, third, and fourth kid, they're watching brother and sister walk, they'll start walking at 6 months, 7 months. Their tibias have not fully formed yet. They're still soft. So the kids, if there's anybody in here who walked before 1 year old regularly, and the earlier you walked, or probably a little bit more, I would bet you might be a little bit bow-legged, particularly in your tibias. Because what happened was your bones weren't hard enough yet, and so that weight and that pressure, they're soft, they kind of burn out a little bit from all that gravity of you walking around, right? So ask that question. It doesn't often happen in the femurs, but you will see it for early walking, but it will happen in the tibias for sure. So don't just merely bow-legged with rickets. It would be more bow-legged. When did your kids start walking? The odds are if they have a vitamin D deficiency, they probably weren't walking earlier than 1 anyways because their bones weren't growing or strong enough yet. And then you use the fraying in that distal femur or tibia as kind of your signs for rickets, right? And on top of that, most common causes are vitamin D in patients in Asia and Middle East. So as we go through these things, there are clues either symptomatically or geographically or age-wise that can help you in putting things higher or lower on your differential. It's more than just looking at the picture. If you really have a grasp of kind of everything in the whole concept, it will help you understand and know what to look for before you just try to memorize all the abnormalities that are in an X-ray. Okay. Questions on rickets? Osteomalacia, right? Osteomalacia, softening of the bones. What ends up happening here, and I'll draw it out in a second, so this one's a little bit different the way I'm set up. The bottom one, the bottom picture is meant to be more normal, and then the top picture is my abnormal. So this is my abnormal. We'll talk about what makes it abnormal here in a second. So what you end up having is this is after the growth plates close. So rickets was typically in peds, which is before growth plates close. So if I say it's after, that means it's in what patient population? Adults. This is not a condition we diagnose in kids typically. After the growth plates close. It's associated with increased osteoblast activity. Wait a second. The bone is softening, but the osteoblasts are increased activity. That's the one that creates bone. So that's counterintuitive. We'll talk about it here in a second. All right? Your symptoms are going to be anorexia and weight loss, muscle weakness, and bone pain. Okay? All the stuff that would go with that. X-ray is going to be your initial exam, and what you end up getting is these radiolucent defects in the pelvis, but primarily what stands out is the transverse lines in the bony cortex. I'm going to draw them out, and I want you to watch with me. I'm going to start down on the left hip and draw these transverse kind of radial opaque lines that are coming across different areas kind of the pelvis, okay? Now I'm going to erase them and do them again. Transverse radial opaque lines right here. Boom, 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 boom. Coming across some of those areas, okay? Why is that happening? What's happening is the bone is softening, decreasing in density. The osteoblasts are trying to fix it, but it can't. It's too much. And those horizontal radial opaque lines is where you're having that increased osteoblast activity, and that's what's popping on the X-ray. It's trying to remedy, it can't. Your osteoblasts, you don't have enough of them, they can't work hard enough to fix this condition, right? So your key sign is going to be those weird horizontal radial opaque lines. Now, fractures are going to be radiolucent. Radial opaque means increased density, not decreased like a fracture. So radial opaque lines across pelvis, right? After growth plates close, thinking osteomalacia. I don't give you a pelvis x-ray with horizontal radial opaque lines. Osteomalacia should not even be on your differential for what we've talked about in this course. So don't put osteomalacia if I give you like a humerus x-ray. Okay. Questions on osteomalacia? Yes, sir.
It is radio opaque transverse lines.
Correct.
So you'll see radiolucent defects.
Correct. It's a generalized decrease in density because that's what's happening throughout most of the pelvis, right? But those radial opaque transverse lines is that osteoblast activity trying to fix that, and that's what makes it easier to find on x-ray with osteomalacia. The problem is not the osteoblast activity, that's just what's standing out on the x-ray to help us out.
So it's going to look fluffy, similar to osteoporosis.
It's going to look similar to osteoporosis, correct. The difference is my osteoporosis isn't having those radial opaque transverse lines. Yeah.
Okay, thanks, sir.
Yeah, no, good call.
So for the normal, those radio opaque lines, is that just like, you're gonna see a ton of them if it's gonna be osteomalacia?
Which one are we talking about? This one
Like,
here?
yeah, right there and
So that's more kind of going downward, it's more vertical, right? That's gonna be more of a nutrient vessel, but yes, you will, this is not a, I have one line, I have osteomalacia. It happens across the pelvis. Yeah, what's your question, sir?
So where are the radiolucent defects in this bone?
So the radiolucent defects is in the main, like the medullary bone area, kind of similar to the osteoporosis. So look how dark kind of this, and I wish I had my normal, we'll use the knee, it's okay, it's very similar, right? So I want you to focus on kind of what that medullary kind of looks like and the color of that there in the tibia and the femur. And now kind of look at how much darker it is in this area here. So that's where you're getting that radiolucency, and you kind of get it up here in the wing of the pelvis as well. Got a little bit right there. Why am I having these little darker, more radiolucent areas in a fairly dense bone, right? The pelvis is a pretty dense bone. There's not a whole lot of reasons for it to have darker radiolucent patches throughout it. And for everybody over here. So I was pointing out this area here, this area down in here, a little bit right in here. Okay, this patient is rotated a little bit, but just kind of showing those areas. Those are your radiolucency areas. But hard to kind of tell, is that osteomalacia just from that, right? So where's my patient history? Do I talk about age? Not so much, except for that it's adults, and then it's those transverse lines in the bony cortex. Some more of an advanced read, okay? There's other things that can help you distinguish between osteoporosis and this one, if you're looking at the two that are very similar. Other questions? Focal decrease in bone density. Osteomyelitis is the only one that we're going to test on. We're going to show you what the other ones look like. So again, normal. Got my normal on the left. And I got my abnormal right there. I compare the two together, and I trace down through. I got my femur coming across. That's my patella, tibia, tracing that down, tracing my fibula around. I'll do all of that. And I mean, everything's intact. I don't have any fractures or anything kind of going on down here, doing my tracing, looking at my medullary canal, everything looks good. But then I have this huge radiolucent, right, decrease in density right there sitting in that tibia. What is that? Okay? What that actually is, that happens to be the first one. It's a picture of a localized osteolytic metastases, right? Osteolytic means it's decreasing that bone density. This is an FYI, but usually what it ends up being is from the infiltration of the bone by cells other than osteophytes, medullary cavity is what's almost always involved. Same symptoms as the osteomalacia, anorexia, weight loss, muscle weakness, bone pain. You have a lot of this for any of these kind of softenings or cancers or anything along those lines. X-ray is the initial exam, okay? Often what you're going to see is that bottom line is what we looked at, irregularly shaped, lucent bone lesions, which can be single or multiple, which is what this guy is right here. Okay, but I'm going to test you on it, and you will see this in HEMONC probably, when they start talking about all the different cancers and everything. White arrow is normal, black arrow shows you how advanced this can get. It's gotten to the point to where the bone is pretty much completely gone. Where's the lesion? Can't make it out. It has lysed almost that entire bone area. It's very painful. Right. Multiple myeloma is another one, right? Malignant proliferation of plasma cells. Okay, asymptomatic in about a third of patients. But of those patients that are having symptoms, 60% of them back pain or bone pain, fatigue, pathologic fracture. We'll talk about what a pathologic fracture is when we get into fracture types. Okay. X-rays, conventional X-rays are your initial study. Like I found it, I do an X-ray in your arm because your arm hurts. I find it. As soon as I suspect that there's multiple myeloma, I'm going to do a skeletal survey. All that is, that's my study of choice. All that is an X-ray of every bone in your body, from head to toe. Because if you have multiple myeloma, we need to know what's affected and what's not affected. So again, I have normal on the left. Abnormal on the right. And you just all those localized or focal decreases in bone density from the multiple lymphoma. So if you catch this, you're just gonna order a skeletal survey. You don't gotta order like a head and neck, both shoulders. You go put a skeletal survey, x-ray goes, they're doing x-rays of everything. I can tell. Yes, sir.
If you're gonna do a full body, why don't you just get an MRI and not have that ionizing?
So first of all, MRI, bones, definitely not a good idea. Right? So I'm looking at the bones. So multiple myeloma is a bony disorder. It's gonna affect, it's gonna affect other things too, but it affects the bone. So an MRI is not gonna give me that. And it takes 45 minutes to an hour for a single MRI. So if I'm gonna MRI your entire body, A, that's super, super, super expensive. And B, we're talking 12 to 18 hours potentially in the machine, if not longer. Right? So that's like per thing. So like when I do a neck MRI, that's like an hour. I do a shoulder MRI, that's another hour. Well, now I gotta do the other shoulder. There's an hour. Start adding it up. I bring you in the room here and give you an x-ray head to toe, you're in and out in 30 minutes. And the amount of radiation that we use on like just conventional x-rays is so extremely minimal, even though no radiation is safe, right? It's so extremely minimal, well, no radiation without risk, that the harming a patient from regular x-rays is very, very rare in today's day. This is why we still do it on pediatrics a lot. Now, when we're talking CTs, which we'll get to, that's a lot more radiation. If we have a better study to do that for certain age populations, we will. And we'll talk about that when we get there. But the best way I can describe an analogy is a chest x-ray is two pictures, right? Everybody in this room gets more radiation exposure from a singular round trip flight anywhere in the country than you get from a chest x-ray. Due to what they use to pressurize the cabin and being closer to the sun, being up in the thin air, being closer to the sun, you get more radiation exposure from a round trip flight than you do from a chest x-ray, medically. So it's minuscule amounts when it comes to regular x-ray. Yeah, of course. Multiple myeloma. See this, go skeletal survey, yeah.
For bone pain, is that just reviewed by palpating and some kind of a generalized tenderness, focal tenderness?
Yeah, usually they're gonna come in, they're just gonna say something like, my arm hurts, like it just aches, it always aches. And when you do palpate, it may also cause some pain from your physical exam. So, but a lot of times the patient will just come in and just be like, it aches, like it's always hurting. So you think it might be arthritis, potentially, we'll talk about some of the arthritis is. It's like, yeah, we'll get an x-ray, see what's going on, see if there's anything going on there, and then this out comes back. Right, so bone pain can present in lots of different ways. It can be from your physical exam if you're good palpation, or it could be just the patient reporting that like, hey, my left hip always just aches and it hurts. Cool. Okay, the one that you can't be tested on, the one that you all care about. Osteomyelitis, okay? Osteomyelitis is basically a bacterial infection of the bone causing degradation and lysis of that bone area. Staph aureus is the most common cause in pediatric osteomyelitis, right? Presentation is within 2 weeks of symptom onset. Fever, it's an infection. The patient has a fever. We haven't yet talked about very many bone issues that we've seen that have had fever. Pain at or near location, overlying warmth and erythema, so like redness, warmth, it's an infection, okay? Here's the catch, x-rays can be normal for the first couple of weeks, which means the findings might be subtle, you may not see it. Osteomyelitis is going to be similar to kind of that avascular necrosis. You're going to start off with an x-ray, see if you see the abnormality. They come back in a couple of weeks and they're still having pain, then you're going to get an MRI, that's the study of choice. Because the osteomyelitis can eat away the bone and destroy the bone. Now, you shouldn't get to this point because the primary cause of osteomyelitis is typically going to be an infection of the bone, usually from an outside source, i.e. open fracture. ulcer, some type of open wound on the body, and you should have treated it, which you will learn, with antibiotics. If you catch this open fracture, or you catch the open wound on the foot or the hand or whatever, and you treat it with antibiotics, your risk of osteomyelitis is extremely low because you're killing off the bacteria that would get in there before they're able to set in and make the infection. Right? So when do we normally see osteomyelitis? Maybe they had a recent surgery, they're still having some pain, they didn't get the right antibiotics, they come in for the follow-up x-ray, like, yeah, it still kind of hurts, you start to see, well, I only get an MRI just to make sure. But if you treated the patient right, then you should be good. Or, my favorite, they had an open fracture, they went to urgent care put them in a splint or whatever, and said, go see your PCN, didn't give them antibiotics, and now you get them a week and a half, 2 weeks later, and they never treated it, and they got an infection starting already. I know all of you guys are gonna do the right thing, but there are people out there that are just burning and turning, no big deal, not my patient, don't care, and they don't give them the right medicine, or they don't give them any medication when they're heading out the door. You see a lot of sinus infections, they give a total wrong antibiotic. But, so what type of patient do we think this one is? Again, normal on the left, abnormal on the right. First of all, what body part is this? That's a foot. What's this thing sitting on the edge here? Anybody know? Yeah, you guys already know sesamoid bones. Good. Sesamoid, that is not an abnormality. Sesamoid bones are normal. Right? We'll talk about some of those variants later. But the big red circle shows the osteomyelitis starting. Compare it to the normal on the left. Look at the degradation of the bone. Look at how it's starting to eat away. Most of the time, it actually starts near the joint because it's easier for the bacteria to get into that area. What type of patient do you think this is? Diabetic. This was a diabetic ulcer patient that the provider did not have them take off their shoes and socks during the exam, did not look, did not notice the ulcer. The patient didn't know about it because of the neuropathy of the feet, so they couldn't feel the pain. And this is osteomyelitis that is caused by a diabetic ulcer. Right? Look at the bottoms of your patient's feet, especially if they're diabetic. Even if they're not there for a diabetic follow-up. If you have a diabetic and they're coming in for shoulder pain, take off their shoes and socks and look at the bottom of their feet. Because a lot of them don't even know what's going on, especially if they live alone. So that's what happened here. I just went over those and those. Questions on any of those things? Okay. I know it's a bit kind of at the complex level of looking at the different bone densities and the disorders, but I get that out of the way, so once we start talking about fractures, we can just run with fractures. Okay? Know your patient population that it could present with. Know the symptoms if they're different, that will help you distinguish between those. And then you can focus on the images to kind of help you go, okay, that's what's going on here, right? How do you use all of the information to get the diagnosis or answer that I'm trying to get you guys to? Okay. I like this picture because words matter, right? What education level should you assume your patients are at? 6th grade is being generous. I think 6th grade is pretty safe. I talked to mine like they're in the 4th grade, right? Not condescendingly, like, you know, but use words you know everybody will understand. This is an actual statement made to me by a patient who went to an urgent care, got an x-ray, brought the x-ray. They didn't look at it. They brought it to me. They were in like a little sling because urgent cares don't cast. Followed up, and they're like, man, and I said it a little bit differently. They're like, man, I thought it was broken, but I was so relieved the doctor just said it was fractured. Huh? I thought they were joking, and I kind of giggled, and then they didn't like that because I really thought they were joking, right? Make sure you use words that the patient is going to understand. So, we are going to cover all of this. Don't know if we'll get through it all today. We might. We're going to cover all of these things. This is just all on one screen for you to understand what the difference is. I'm going to break these down on each of the slides, show you what it is, but it's just one easy place for you to make sure you know what the words are because words matter. These are words we use when talking to one another. These are not words we use when we're talking to the patient, except for like dislocation. Almost everybody knows what dislocation is. But these are words that we use when talking to one another. Alright, we're gonna know how to recognize all these things, dislocations, subluxations, recognize fractures, describe the fractures, talk about joint diseases, which is like arthritis and things along those lines, and then talk about different bone lesions. First thing, dislocations. Okay. Joints dislocate. Joints don't break. Bones break. Bones don't dislocate. Bones can be displaced after they fracture by moving, but they don't dislocate. So you don't break your knee. You break your femur, or you break your tibia, or you break your patella. You didn't break your knee. Your knee is a joint. You can't break a joint. It's not a bone. Right? So when you're talking to other providers, like, hey, I got somebody with a broken elbow. No, you don't. Don't tell ortho you got somebody with a broken elbow. You have a broken radius, a broken ulna, right? A broken humerus. You can have a dislocated elbow, but you can't have a broken elbow. Saving you from headaches when you get out there and you start doing consults, right? So, normal, knee x-ray, abnormal. Now, I like this picture because if you just look at this one, don't look at this, just look at this one, which way does it look like that femur has moved? Right? Doesn't it look like it's moved towards us? This is what I was talking about, how your mind plays tricks on you. It looks like that femur is sitting in front of the tibia and fibula. You see that? Like, that's what my brain tells me. This is what my eyes tell me it looks like. This is the lateral of the same patient. That femur is behind the tibia and fibula. That is why for dislocations, for many things, you need two pictures to figure out which way is this dislocation. You can't do it with just one, because this looks like the femur is in front of the tibia, but it's not. Okay? Now, how do we name this? We name this for the direction based on the distal fragment. So what is the distal fragment of this dislocation? The tibia and the fibula, right? So this is an anterior knee dislocation. This is an anterior knee dislocation because we name it for the direction that the distal fragment is compared to the rest of the anatomy. Now, everybody's looking at this and go, well, sure as heck looks like the femur slipped off that tibia and popped into the back. Why do we name it that way? Because I don't know how this happened. I don't know if the femur slipped off the back or if the tibia came forward and came out this way. You weren't there, you don't know. So in medicine, we had to come up with a standard way so when we're talking to one another, we all paint the same picture in our head. And they just decided that when naming dislocations, you name it for the direction that the distal fragment is going. Okay, questions on that? So, anterior knee dislocation. Subluxation. Okay, subluxation. Similar to a dislocation, so I have normal here, don't worry about this, that's a pen, right? So what you'll see, sometimes you'll see this on x-rays, is because the patient went into x-ray and they're like, where does it hurt? And they're like, it hurts right here. So they'll put like a little pen to point to the radiologist of like where the pain is. This is a normal x-ray even though, but that's what that is. But you have your dislocation where I have complete separation between the two bones, right? They're separated, they are not touching anymore. Then I have subluxation. Subluxation is where it has started to shift, but it hasn't entirely shifted yet. So here's my normal, look at how my thumb is sitting. There's my subluxation on the abnormal. It's starting to shift and potentially could be a dislocation, but I still have contact. If there's still contact between the two bones that make the joint, it's subluxed. It's not dislocated yet. It needs to be completely removed. Still naming it for the distal fragment, and this is where you gotta think about this. When we're talking distal, we're talking anatomic position, right? So which is the distal fragment? the distal fragment, let's label it here. 1 and 2, what's the distal fragment? 1 is the distal fragment, right? It's not always the one that's inferior on the x-ray, it's what's the distal fragment per anatomy. And now which way are we gonna name this then? Okay, that's where, right? So we're saying medial, right? So when we deal with the hand and wrist, because it can get confusing of medial and lateral, we don't use medial and lateral in the hand and wrist. We use radial or ulnar, because no matter which way my hand and wrist move, the radius and ulna go with it. It stays where it's supposed to. Medial and lateral can get confusing, so we don't like to use that. So in this case, we're talking distal portion is shifted this way. So I turn around and I look and I go, okay, well here's my ulna, here's my radius. So here's my ulna, here's my radius. So that is going to be an ulnar subluxation. Does that follow? It is annoying. I agree with you. I didn't make it up. I just got to teach it to you. Go ahead. Can we do it again? I'll start over. Yeah, that's okay. Right? So, first, our subluxation is there, right? So, I have 2 fragments of my subluxation, 1 and 2. 1 is my distal fragment. Because it's distal, I want to know what direction that fragment is going, and that's how I'm going to name it. So anatomy-wise, right, my radius is here, my ulna is here on this side. So because the distal fragment is shifted that way, it's shifted towards the ulna, so it becomes an ulnar subluxation. Not in the hand and wrist, we like to use radius and ulna. So if we got there, yes, we would use dorsal and ventral if I had that image, but I don't on here, so I didn't want to confuse anybody yet. I saw a couple of hands. Go for it, ma'am. Yeah, so when naming subluxation, what I would do on this one is, so that's the proximal phalanx, so I would say it's an ulnar subluxation of the first proximal phalanx. So I would name the bone. Right, because that's the part that's shifted. Yeah, the last one when I said an anterior knee dislocation, you can still very easily say anterior dislocation of the tib fib if you want. That's an appropriate way to say it as well. Just the knee's a lot easier to describe because we just got those bones that connect, right? But here, because there's other bones, we name the bone. Yeah, what else? Yeah.
So since you don't have the second picture, you can't really tell if it's dislocated.
So I can tell it's not dislocated because I still have connection here.
But if it went back, like if it went backwards, kind of like the last picture.
So I can't tell if there's any changes between dorsal and ventral movement correct. Because I don't have that lateral, so I have no idea if it's shifting dorsally or ventrally. That is accurate. But with the information I have, this would be an ulnar subluxation. I'm pretty confident it's not dislocated because I don't have almost any overlap of those bones, right? So when it's dislocated, it's completely separated. Muscles and ligaments are going to contract and you're going to have kind of overlap like we saw in that knee x-ray. I don't really have a whole lot of that here. But I don't know any movement dorsally or ventrally because I don't have that lateral. Yes. Yes, sir.
Would you treat a subluxation and dislocation?
That is a wonderful question for ortho next semester. Wonderful question. The easy answer is no. Right, you're going to treat it differently because one's more severe than the other, but I'm not going to dive into those waters with you right now. Okay? And it depends on, and it also depends on what's subluxed, what's dislocated, how severe is it. So there's lots of factors that go with that. So Major Davos would love to have that discussion with you in about 4 months. What else? Okay, dislocation, subluxation. Got some? You kind of twitched.
I do. So you said your college is of the first proximal phalangeal joint?
Phalange, yeah, or phalanx.
Phalanx.
Because phalange is effectively plural.
Okay. And then what about using like MCP? Do you not use that?
So that, because again, we have a subluxation, we're not fully dislocated. So it's just, use words that are as specific as you can, right? If you think ends first MCP, then yeah, technically that could also be correct, right? So if you said, hey, I have an older subluxation of the first metacarpal phalangeal joint, I could probably paint that picture, but I can paint it a lot easier if you just told me proximal phalanx, right? So you're not wrong, it's just better.
So would you do the same thing that if it was the dislocation, you still call it the first proximal phalanx?
I probably would in the hand because there's just so many different bones and areas. Like you say MCP to me, I'm like, yeah, it could be that. And like, this sounds silly, but how do you know the person you're talking to? Didn't, because it happens, didn't confuse the MCP with the CMC, right? All these abbreviations. So when dealing with like the hands and the wrist and that area, there's so many different bones and joints. I find it more descriptive just to be like, this is the bone that's moved, this is the direction it's moved, it's not supposed to be there. As opposed to dealing with the joints, whereas knee, shoulder, pretty kind of clear and self-explanatory in that aspect. Yeah,
Real quick, sir,
you're
so
still gonna get your break, I just wanna clear this topic up before we break, so it's coming.
you will give us orthogonal views of, if you were to give us something that's on the examination, correct? You're not gonna make us guess if it's only, shifted to the right, it's not like dorsal or.
So if I were to give you this, right, and not give you orthogonal views, I can't ask you to tell me dorsal or ventral because I did not supply you with that image and that information. But I can give you something like this and expect you to find the subluxation of which bone is it and name it for ulnar versus radial based off of something like this. But no, I cannot add in dorsal and ventral on just this picture because I did not give you enough information. Saw another hand somewhere. All right, go ahead and take a break, come back at 5 after. All right, I'll be here for any questions. Yes. Yeah, so that's the problem. So we're talking about, so it's not though, because patella is not necessarily part of the joint per se, and the patella is not actually free-floating. We're gonna talk about that in the beginning. It's actually in the quadriceps and patellar tendon. So it doesn't really, so it can't really go anywhere because it's not a part of the joint. But it can shift and move if there's a patellar tendon or a quadricep tendon. And that's really what we're talking about now, is a tendon. The only way your patella can move is to be like you fell on it, watching the patella, and both of those things have a that would be a distraction from it. They got pulled apart, but you really don't have a whole lot of patella dislocations outside of somebody who says like, hey, it popped out, I'll be back. I wouldn't get hung up on it. I wouldn't get hung up on it. It's so rare, I wouldn't worry about it. And you really won't see it on X-ray because the odds are they're going to pop back there. They're going to. Yeah. I haven't shown you anything with the skull, so I'm going to see why we get to actually talk about the skull. A lot of stuff. See why. Let's just know that it can be there. So when you do skeletal survey sometimes, you're right. No, that's a different type of machine. This one is, yeah. This thing with medicine is like so many terms just kind of like go around, like it's like no big deal, like PFTs. There's an actual thing that are pulmonary function tests. When like there's things like spirometry or something like that, actually PFT is really really good spirometry. But we all just call it PFT. In that academic setting, it's just like so what it could be, and I don't know this, right? It might be the same machine, and maybe a different program that saves that can do it, and maybe that's why they call it that, because they're using the DEXA machine but maybe there's another program that can do that soft tissue stuff. I don't know, there might be. But it's not the same skin, right? So what they're scanning for this flat stuff is not going to be the same type. It's not also gonna give you osteoarthritis. They call it low radiation.
I mean, it's like, what I mean is like, the one scan, and if you want to go back to the
Don't have to. So what it does, it just takes a picture of the spine and the one hip. It just takes that one picture, and what it's doing, is you know, I'm talking about the attenuation and how like the radiation kind of gets absorbed down the floor. The program is then calculating how much radiation was absorbed, and what the densities are of that node, just from that little picture to see how it works. So like the views and stuff, all that is now, you know, based off of race, sex, and all of that. What the attenuation is actually should be. And then it converts it to what yours is, that's how it works. Yes. Make sure there's no open wounds on the cardiac surface of the foot. You're learning more and knowing about it. Any type of little surface on the bottom of your feet. Something with diabetics is they lose those rhythms in their feet. So you look at it, you see, like, I actually got my sister. She's like, oh, I'm just going there. So they can't help you. So those open also wounds that allow the bacteria to get in, they don't feel the pain. You got the feel of the open wound is probably due to they stepped on something, they cut something, they got the whole immune system really because of the diabetes. So then it got infected, it got worse, got even more worse, and then the infection got into from the infection.
So for this, because this was like just and it's bacteria that we're gonna No. So like, doesn't matter what side it's going, it's saying what side that comes up. This is happening. Yeah. I don't worry about real life. I hate the field. I didn't do it because you were
When I leave the room, I didn't realize you were going to do it. All right, you're off the hook today. To where like it's like just and it's still sunrise. But usually dislocations, yeah, you some of them you're going to use that off afterwards and take down. Done a couple of shoulders. couple of shoulder dislocations. I haven't done an elbow. I was really hard to dislocate. It takes quite a bit of time to do that. I haven't done an elbow.
I see that. I thought they were.
So I have quite a few shoulders
Because in my mind, I'm just saying like did you
It is, and when I say I've done it, like I've had help. I've had another provider come They had a small
I like it. I like what I don't have to
the day I'll keep it at like 74, so when I go to bed, I'm like 76. When I work study in the kitchen, I like the seconds or something.
Like it was like 3 days.
January, February is like
Like they also had a weird one here,
I like the ghetto.
They're not bad. It was just more like
It felt like a glorified.
yeah, it was like you could be doing nice. They put you in the one there. You walk through here. They look down.
I like the I like the music. Because all the dumb kids
Yeah, it's more. You know, your vehicle is all yeah, like I said,
Alright, let's take our seats, let's jump back in. Jump back in. Alright, come on, let's go. Go through any final questions on dislocation and subluxation. I'll probably have some later on if we go through it. What segment do we name it for? The direction of what? Distal segments. Good. Alright. Just talked about it. There we go. Now we're going to start recognizing fractures and things to avoid when trying to find fractures. And we're going to talk about how to describe all these things. Things we want to avoid. Normal variance. One of them y'all already picked out. Sesamoids. Right? Sesamoids are not fractures. Okay? So watch out for those. Ossicromial. I'm going to erase it and I'm going to draw it again. This guy right here. This is an ossicle. It's an accessory bone that some people can have up in the shoulder joint. This line is not a fracture. It's a joint line due to that ossicromial. Now, if I were to get a shoulder x-ray, and once you see more shoulder x-rays, you will see what normal looks like, so you'll get used to the normal. This will jump out at you. How do you think we can verify whether this is some kind of funky fracture fragment lying around, or this is my normal variant? Or in the other shoulder. If they have an osteochromial, almost guarantee they have it on both sides. They have it on both sides, normal variant, move on with life, they have an osteochromial. Sucks for them because they'll have some shoulder pain and some range of motion kind of tightness and issues because of that extra bone there, but it's not an abnormality that is due to a fracture or anything along those lines. The scaphoid. We talked about the scaphoid already a little bit. Really what this is showing you is watch out for old fractures. Old fractures that get healed and don't unionize together can be mistaken for new fractures. A couple of ways you can tell this. There's two primary ways. One, when I look at it, if I follow my cortex all the way around, both of these pieces have actually smooth and two cortexes. They look like two bones right next to each other. That's step one. Step two is, what else can I do? Ask the patient, right? It seems simple, but ask the patient, hey, you ever fractured your scaphoid? Oh yeah, I did that 3 years ago. Great, that's just an old fracture. Are you hurting there right now? No, that's not where my pain's at. My pain is more over here. Okay, great. That's not something I'm concerned about, right? Because what will happen is if you don't ask those questions, you'll be like, oh, found it, shiny toy. Shiny toy. It's not even why they came in. That was from 2 years ago. It just never came back together again, right? And that can happen just about anywhere. It's just the scaphoid picture is the one that I have here. And we'll talk about non-unions a little bit later and kind of what they look like. So, don't let those guys trip you up. How can I distinguish between a sesamoid, an acute fracture, versus an old fracture? This chart will help you understand how to distinguish between the two. So, is there an abrupt disruption of the cortex? An acute fracture, the answer is yes. Sesamoids are no, old fracture, maybe, right? Bilaterally symmetric, sesamoids, almost always. Almost always. That fracture line you're seeing on the x-ray, is it smooth or jagged? If it's jagged and there's pain in that area, it's probably an acute fracture. If it's smooth and there's no pain, probably an old fracture or sesamoid or accessory ossicle. And then is there a bony fragment of the cortex completely around it? Right? No on the acute fracture. Yes on the sesamoid or accessory ossicle. And everything about old fracture is possibly, maybe, it depends, I'm not really sure. Right? Which is why the magical question for the old fracture, do they hurt in that area? And have they ever fractured that bone before? The answer is yes. How long ago? And is it painful there? That's going to tell you whether it's old or new most of the time. Healing process. Right? Now don't let this fool you. This is a pediatric patient. How do we know it's pediatric? I'm missing like bones and joints and stuff. They're not just missing, they're little kids. They haven't come back together yet. Now, when it comes to pediatric, outside of Salter-Harris fractures, they're not going to make you read a whole lot of pediatric x-rays. Why? Who knows when every physes fuses? And at what age? I sure don't, right? Most of your regular radiologists can't even remember that. That's why there is specialized pediatric radiologists when it comes to pediatric imaging, right? So they don't mess it up. And even then, when I give you the ages when you learn about it in pediatrics, right, it's a good answer, it's a range. Between 4 and 6 years. Between 18 and 24 months. Between 7 and 10. Great. That means everybody in here probably fused in different areas. So how are you establishing whether or not that line at your level, what I'm trying to teach you, right? Whether or not that joint line is a fracture or is it actually just normal because that growth plate hasn't fused yet? I'm not going to make you memorize all that, except for when it comes to Salter-Harris fractures, and we'll talk about those because those make a big difference because those need surgery to fix that to prevent growth delays. But that's like one of the only pediatric ones I'm really going to kind of focus on a lot. But this just goes to show you the bone healing process. So we have the fracture on day 1. On day 4, it's still kind of there. It's shifted just a little bit. But already on day 7, I have this cloudy kind of circle around the fracture. Everybody see that? That's that periosteal reaction starting. The bone is starting to heal. okay? By 2 weeks, you can't even really see the fracture anymore, but you can still see that the bone is kind of a funky shape. And then the beauty part about pediatrics is by 6 months, the bone looks just like it did before. This is why in kids for clavicle fractures, a lot of times we just leave it alone. And you won't even know by the time they're adult that they had a clavicle fracture when they were a kid, because we have this awesome ability as kids to be able to just heal it and have it go through. Adults, not so lucky, right? Because I turn around and I go, okay, so at 6 months, this pediatric looks like they never even had a fracture. Now at 6 months, on this adult that needed surgery, I can still see the bump from the healing of the bone, right? It takes longer in adults sometimes than it does with pediatrics. So this is just one that needed a rod. This is a femur, and they just needed the rod to go all the way down because they weren't going to be able to stabilize this. Why? Because the femur is the primary weight-bearing bone of the lower extremity, lower body. Yes, sir.
Is that something you can tell about that, or is that just?
It's still healing. Yeah, it's still healing. Is it possible this is what it's going to look like forever? It is. I don't know yet. I would want another X-ray at like 9 months, maybe a year, just to verify that. So this could just be the new you, or it could still slim down back to fit again after some more time. Yeah, I mean, what's a little extra bone? You know, it's helpful. Okay. Now, what happens if we have occult fractures, which are indirect signs of fractures? I don't see the line, but I see other things that tell me that there's going to be a fracture there. So, soft tissue swelling, not always an indicator, but if you see it, you should look a little bit harder, right? Because if you sprain your ankle, you're going to have soft tissue swelling. But if you take a direct impact and you have soft tissue swelling, maybe you look a little bit deeper in that soft tissue to see if there's a fracture there that maybe you missed the first time around. Blood in the joint with hemochromatosis, we will talk about that. There is one particular area in the body that you can literally not see a fracture, but based off of one other abnormality, because there's blood in that joint, it's the elbow, there's a fracture somewhere there, even though you can't see the fracture line. And we will hit that pretty hard when we get to that area so you guys can see it. Sometimes the fracture lines tend to be blacker and more radiolucent than nearby other lines. You can have a discontinuity of the cortex, we've already talked about that. But the key sign of the indirect fracture, or those occult fractures, or like the stress fractures, is you may end up seeing that periosteal reaction a couple of weeks after the injury or the pain, right? You won't see the fracture, but you'll see that periosteal reaction, okay? Reference only. I'm not testing you on this, but this is helpful when you're trying to figure out how fast or how slow something is going to heal and things that may delay it, okay? All right. So, big yellow arrow tells you, but I'm going to give you a second. I want you to look at your normal, go through your stepwise process. I have a big yellow arrow because of the soft tissue swelling. That's what I'm pointing out. I want you to go through your stepwise process, and then I want you to look at my normal and my abnormal, and I want you to see if you can find the fracture. It is subtle. Give you a little bit to kind of look at it, and then I will draw it on the screen in just a second. All right. Okay, I'm going to erase it. I'm going to draw it again. Right there. Maybe for my sharpshooters out there, maybe that too. Maybe that too. So, that subtle radiolucent line definitely got the tibial fracture. And because of the soft tissue swelling, maybe I have an occult fibular fracture somewhere there that I can't see. But I don't know for sure. But this is the fracture I wanted to see if you guys are able to pull out. If you did, awesome. You didn't, it's okay. It's a subtle one, right?
Sir,
Yes, yes.
is it possible
Here?
Yeah.
No. We'll talk about that more when we see what the normal anatomy of the ankle is supposed to look like. But, so these are actually two different views. This is my mortise view, my oblique view. This is just my regular AP view, but that's all normal overlap. Yeah. But saw somebody else had their hand up? No? No? Okay. So, right, so at first glance, you might be like, hey, this is a normal x-ray. Maybe I overlooked that subtle fracture. But then I see that massive soft tissue swelling sitting right here, and I'm like, you know what, I'm gonna go back and I'm gonna double check. I'm gonna double check, look a little harder, make sure I didn't miss something. Yes, sir.
Did you say that was called fibula?
So the one we see is a tibia fracture. Because of the soft tissue swelling, there might be an occult fracture is a fracture I can't see on x-ray. So because of the soft tissue swelling, I'm saying there might be an occult fracture on that fibula because of where that swelling is at. Might be. It's a sign that there could be something, especially when I see another fracture already on the film, which is where that tibial fracture is. That tibia fracture is not an occult fracture, right? It's just a very subtle fracture from the injury that the patient had. Bring the party in. All right. Blood in the joint, hemarthrosis, primarily in the elbow. Bear with me on this one, okay? Bear with me on this one. This is my normal, and there are two things on here. There's the anterior fat pad and the posterior fat pad. Let's focus just on the normal. Look at your densities, okay? Look on your screen. It might be hard to see it on this screen, but there is an area of radiolucency right there. Soft tissue is one color, and you get a dark area sitting right here. That's an anterior fat pad. That's normal. That's supposed to be there. Hang on. When I go to the black arrows and I go to the abnormal, that radiolucency looks more like this. Okay? I don't want you to marry yourself to the anterior fat pad sign. Know that a sale sign, like know this, that if somebody says there is a sale sign in the anterior fat pad, that you're concerned about an occult fracture in the elbow, probably the radial head. Okay? Know those words. Know those words. But when you're doing images, what I want you to do is focus on the posterior fat pad sign. Why is that? Because the anterior is visible on both, regardless of normal or not normal. You gotta play this game of like, what's the shape of it? Does it look like a sail? Is it normal? I don't really know, right? But my posterior fat pad, I'm gonna start on the abnormal first. Do you see the radiolucency or the darkened area right up against the posterior aspect of the humerus, right where the white arrows are? Okay, on my abnormal. Now look at my normal. It's not there. You cannot see a posterior fat pad sign on a normal x-ray. It's not present. If you see a posterior fat pad sign, it is always abnormal. And the reason is there is bleeding in the elbow joint and there's not a lot of area for that blood to go. There's some small bleeding, likely from a radial head fracture. You can see how small that fracture is in the black arrow on the radial head there, right? But it bleeds and it doesn't take much blood to put a little bit of inferior pressure on that fat pad to make it kind of stick out a little bit and become present on an x-ray. Know the anterior fat pad stuff, because that could be a pants question, that could be a way people are talking, oh yeah, those who are really good at x-rays, like yeah, I see the sale sign, I see the anterior fat pad, so I know it's a positive thing. But the one that is, if it's not there, it's normal, and if it's there, it's abnormal, is that posterior fat pad. That's what I want you to spend your time trying to find. Because a lot of times, you won't find that fracture. It can be difficult, especially in pediatrics. So you overlook it, you go, hey, this elbow looks normal. I've done my systematic process, the elbow looks normal. Before I call it normal, I'm checking for a posterior fat pad to make sure that there is not a fracture, more commonly in the radial head, but it could be anywhere in this area that there is not a fracture that is causing some hemarthrosis, causing me to see that posterior fat pad sign. Questions on the fat pads? Yes, sir.
How often do both of them present versus only one shows it?
So usually they both present. Usually it's not one or the other, right? It's just playing that game because the anterior is always there. It's just playing that game of like, is this officially sale sign? Is it not? That can get kind of complex and you'll like argue with yourself, which is why I say just shift to the definitive posterior yes or no. But usually they're both present in the hemarthrosis.
So you're saying it is possible for just one to be there?
Anything's possible in medicine,
Yeah.
right? The second I tell you it's not, you're gonna like email me in like a year when you're on phase 2 and be like, haha, gotcha, sucker, right? So anything is possible in medicine, but usually it is both of them. It's just that that's the easier one to pull out. Because then you just gotta play with it, is it there, is it not? As opposed to, what's the shape, is it enough, I don't really know. So really what you can do, if you like the anterior, you can play the game with the anterior fat pad, and then if you think it's positive, then shift to the posterior to verify, right? You can do that too if you want to. Because posterior fat pad is always an abnormality if it's there. Any other questions on that? Okay. Periosteal reaction. This is where I'm kind of telling you here, right? I have the periosteal reaction circled, right in there and right in there. I'm going to erase that part now, right? I don't see a fracture on that x-ray. But I know there was a fracture there because I have the indirect sign of a periosteal reaction. If there wasn't a hairline fracture or something along those lines, there would be no reason for there to be periosteal healing. Right on this edge here and right there. There and there, right? So this is when that kid comes in, maybe they're playing on the playground and they've been complaining their leg hurts. They've been complaining their leg hurts for 2 weeks. Mom and dad are finally like, my God, you won't shut up about it. Fine, we'll go to the dang doctor. Go to the doctor, they get the x-ray, you see the periosteal reaction. You can safely tell mom and dad, hey, when they fell, what they did, they probably did have a small hairline fracture because I can see the healing. No worries, it's gonna hurt for a little while. We don't gotta splint or do anything, just keep an eye on them. You know, Tylenol, ibuprofen, depending on the age for pain. They'll probably get better, but there was a small hairline fracture and it's healing up and he should be fine in a couple more weeks, 3 4 weeks, whatever the case may be, right? So you can call that a fracture, even though you can't see the fracture because you have that indirect sign. Does that follow? Subtle radial head fracture. Got the red arrow there, so I'm going to draw on it. Right? Very subtle cortex irregularity right there. Compared to my normal. Right? And so I have that, right? That fat pad sign we talked about, that's only on that lateral x-ray. You can't see it on this one. Because I don't have that posterior humerus thing that I'm looking at. Yes, sir?
So on the previous slide,
Yeah.
periosteal reaction, how do we differentiate that between an old fracture that might have just healed, kind of like the previous one?
So the previous one was an adult with a surgery and a rod that's taking time. Remember the pediatric one was like a nice clear bone? Pediatrics, not gonna have a periosteal reaction, it's gonna sit there. It's gonna heal smooth.
So in an
And on top of that, 2 weeks after the injury, and that's where they're hurting, and that's their pain, that's the area you're looking at. Right? It's a whole patient concept. Now, if they weren't having any pain there, they didn't have any injury there, and you just happen to find that, that becomes a little bit more of a conversation. Maybe it's positional, maybe it's not. But if they're coming in with pain in their lower leg for the past 2 weeks, complaining, they fell off the playground, or even mom and dad don't know what happened, they just been limping and complaining of pain, I'm gonna call it an acute occult fracture. Good question, right? It's where a lot of that patient conversation, history, presentation of illness, how does that come into play to help you distinguish over what's probably going on here? Okay. You got this one?
Can't see it.
Can't see it? Oh, sorry. Right? Adult or pediatric? Pediatric. Pediatric, how do I know? There we go, right? Got my growth plate, my physes. Is that a fracture? I don't know. I wouldn't make you pull that one. There ain't no growth plate there. Alright, that's a complete fracture. Okay. Just wanted to show I did so many subtleties, I'm like, I gotta throw something in that's not super subtle. Alright, let's talk about incomplete fractures now. So complete fractures go all the way through the bone. Straight through. All the way through. Both cortices, straight through the bone, and maybe a couple of pieces, we have a complete fracture. Okay? Incomplete fractures. We'll talk about torus in a minute, but incomplete fractures are fractures that start but don't go all the way through the bone. This is still one piece. This is still one bone. Okay? Mostly in peds, there's one case where it's not that I'll show you, but mostly in peds. And why is it mostly in peds? Kids are bendy. Their bones haven't hardened yet to where they need to. So kids' bones bend and don't break a lot of times. So when you have this right here, where I have a complete cortex on one side that is bent, and then I follow my cortex here, and I have the gap, and I have a fracture that comes in, and this is on both bones, right? So they bent, broke on one side, didn't go all the way through, I have an incomplete fracture. That's called a green stick fracture. Where do they get the name from that? Go out here in the springtime, grab a twig or a plant that's green, that's healthy and growing, try to snap it in two. You can't. You'll bend it, one side of the cell wall will break, but it won't just break in two unless you like grab, twist, and pull, right? But if you just try to break it, it just gets that crack on one side. It's green stick, right? That's where they got the name from, is like the plants. We as adults, we're like the dead brown twigs that fall on the ground, we just snap in two, right? But kids, it's like that green stick, right? Bends on one side, full cortex is there, fracture on the other, incomplete, doesn't go all the way through. Okay? Alright. Torus fracture. No fracture line on this. But what I have is a bulging cortex. Right there. And it's kind of hidden right here on that bone there. So what happens is the kid falls, sometimes on their outstretched hand, kind of smushes the bone this way, and again, it just bulges out of the cortex a little bit, like the bottom of the Greek and Roman columns. This is a torus fracture. This is only a pediatric fracture. Adults do not get this. We are not bendy. So torus and green stick fractures are both incomplete fractures, right? Because to have a complete fracture, you need at least two pieces. But neither one of these things has broke the bone into two pieces. It's still one piece, it's still all connected. They're both incomplete fractures. One smushes and it bulges out, which is the torus. The other one bends and kind of breaks, but doesn't go all the way through. Questions on those? Avulsion fractures. These typically happen anywhere there's a tendon insertion. What this is usually a sprain or a strain of a tendon, sometimes a ligament, but a lot of times a tendon, and it basically rips off a piece of the bone. These can be complete or incomplete, it just depends. Well, here we got our normal, right? And here we have our piece that kind of ripped off. All right? And so what happens is the tendon got pulled probably down this way, and it ripped off this area of bone from the insertion point. Sometimes that tendon ruptures, sometimes it doesn't. The easiest way to tell is it a tendon insertion point? That's where anatomy comes into play, right? If I have something like that, like my mid tibia, there's no major tendon that kind of attaches there, but in the hands, there's a lot of those. So we see it more commonly in the hands, sometimes the feet. We'll see bigger ones, sometimes like down in the oscalcis with the Achilles tendon that goes in there. You can see an avulsion fracture, it just depends on the injury. And then a lot of times you can tell when you look at the fracture, a lot of them are fractured into kind of like these clean lines. This almost looks like it was torn away. It looks like a puzzle piece where I wish I could just kind of like push it right back in and it'll kind of fit perfectly in there. But the avulsion fracture is a fracture and a tendon insertion. Basically, the tendon has pulled part of that bone off of that area. Most common ones you're probably going to see is going to be your mallet finger. Okay? You don't need x-rays to diagnose either of these things. But if you see it, that's what it's going to look like. Because what happened? I ruptured or strained my extensor tendon. You diagnose it in clinic by you isolating their finger that is currently bent, and you go, hey, straighten it out. And they can't do it because the tendon ruptured. So their finger is stuck like this. So you have to isolate this, because otherwise they'll be like, oh look, I can do it. Not this joint. Isolate everything but the dip, and then have them try to straighten it out. They can't straighten it out, you got a mallet finger. You'll get the x-ray to confirm. You'll call ortho, they'll tell you to put it in a stupid little split thing, and they'll see them in like 6 weeks or whatever, but, right, ortho will tell you that treatment. But that's the mallet finger, right? Your extensor tendon causes that avulsion fracture. Because tendons are too strong. It's really hard to tear tendons. So it's a lot easier when you injure the tendon for that fleck of bone to pull off than it is to actually tear the tendon. And that's what causes these. Ligaments tear a lot easier than tendons do. That's why we see all these ACL tears, right? MCL tears. How many patellar tendon tears have you heard of? Or quadricep tendon tears? Not many. It can happen, but not many. Anyways, so there's that. Jersey finger. It's the opposite. Still an avulsion fracture, but now it's the flexor tendon. Same concept. They come in, hey, flex it. They can't, because that tendon has ruptured and has pulled off a fleck of that bone with it. They won't be able to flex. Jersey finger. You're going to see this during flag football season. I think I've seen double digits of jersey finger flexor tendon injuries. Always flag football season. Y'all think like during the NFL or something. I don't know. It's not that serious. You got a little plaque that's like 6 by 6. Like, it's not a big deal. I've seen a lot of flexor tendon injuries from intramurals from flag football season. That's why you never see a medical team out there. We ain't doing that crap. Alright. So if a 25-year-old male presents with inability to fully extend his finger after a game of basketball, what injury did he likely sustain? Alright, mallet finger. There you go, there's a question. Okay, pathologic fractures. Straightforward definition. Any fracture that goes through pathology or a bone lesion. Automatically a pathologic fracture. We're going to learn about incomplete fractures like we did, and complete fractures and obliques and all that stuff. Once a fracture goes through pathology, we just call it a pathologic fracture. Because guess what? The fracture is the least of our concerns. What is that, and why is it there? Right? So that would be an oblique fracture. We haven't gotten to that yet, but we would call this oblique because of the direction it's going. Maybe call it incomplete, but once it enters that pathology or that bone lesion, it becomes a pathologic fracture. No matter what you were going to call it before, it now becomes this, automatically. Stress fractures. We briefly talked about it before, so we'll go through a little bit quicker on it this time. We talked about what a stress fracture is, right? Weight-bearing muscle forces, muscle fatigue. It typically happens when somebody hasn't done anything for 6 months to a year and they got their PT test in 2 weeks. And they're out there running 5 miles a day, well, trying to run 5 miles a day. And they come in 2 days beforehand because they can't walk, right? Yeah, profiles, right? Anyways. I spent multiple years in academic medicine. I used to not give people profiles if they were a frequent flyer. Every 6 months, weird. Is shin splints every 6 months? Anyways, but you will see it more commonly too, actually, in your elite athletes, believe it or not. They got a triathlon coming up, they got a marathon or a mega marathon, and they got like now these like 100-mile like teen race things that people do. Y'all are crazy who do that kind of stuff. Run through the desert for 100 miles as a team. But they'll be getting ready for that kind of thing and they'll start developing stress fractures, right? Most of the time, We are not gonna order imaging on these things, because we already talked about it. The answer is rest, get better, and then get back into activity slowly, right? But if it becomes chronic and it becomes frequent, then we're gonna go ahead and do it and make sure we're not missing something else, right? It's probably a stress fracture, get better, don't get any better, we're gonna make sure we do an x-ray. X-ray is the initial study, but it can miss up to 85% of these things because they are hairline fractures. They are super subtle, they are hard to see. Doesn't really matter because the treatment is the treatment, and most of these patients will get better. If you get to the stage of having to order a more definitive study, which I will say for ortho, of when you draw that line and make that call, know that an MRI is going to be your study of choice. Yes, CT and bone scans can do it as well, but MRIs are much more common than your nuclear medicine scan equipment, and CT is radiation, MRI is not. MRI can give us that answer, and this isn't emergent, right? We're not doing surgery on these things. The treatment is anti-inflammatories and rest, we're just trying to confirm it. It's not like we're gonna delay treatment. If they gotta wait 3 to 4 to 6 weeks to get their MRI, they can still be treated for this and be taking care of themselves while they're waiting. So imaging is not of the essence for stress fractures, which is why we'll falter to the MRI as opposed to the radiation of the CT, because they can wait, okay? The yellow arrow, so again, normal, yellow arrow is the x-ray. Ask yourselves, without the yellow arrow, would you have noticed that fracture? It might be yes. It's not the most subtle stress fracture I've seen, but it's still a really subtle abnormality. But look what happens on the MRI. Look at all of the increased signal. This is all inflammation in that bone area from the stress fracture. This is what's causing all their pain. So this is why our MRIs are study of choice, because it'll pop that up and that will show that, oh, you have a stress fracture in that area. Yeah.
I'm trying to figure out, so we talked about CT being better for bone, but we're using an MRI in this case.
Yep.
Is that just because we're looking for inflammation? Like, why are we specifically looking at a
Bingo.
bone with an MRI?
You got it right there. It's the inflammation that tells us the stress fracture is there, right? Because the fracture can be so small. We're more looking for the reaction inside the bone with the stress fracture, the inflammation, than we are looking for the actual fracture. Because the fracture is so small, we may not even see it anyways. It's more the inflammation inside the bone, because that's what's really causing the pain. And again, because that's all I'm worried about, non-radiation, you can wait weeks, I'm not worried about it. Right? Not worried about getting you a CT right away. Questions on that? No. What do we got here? Subluxation, right, not a dislocation. I have just a little bit of contact right there. Okay? Which way? Ulnar. This is the distal fragment. Good. That's the professionals. Love it. What distinguishes complete from an incomplete fracture? Complete is all the way through. Neither one of the cortices are intact. Good. When the tendon is stronger than the bone, what kind of fracture do we normally have? Avulsion. Wonderful. Let's learn how to describe them. Basics, number of fractures, yada, yada, yada. We'll talk more about all this stuff. Okay, how do I describe it? First, what bone? Tell me the bone. And tell me the real bone. Clavicle. It's not a collarbone. If you're talking to the patient, it's a collarbone. When you're talking to a colleague, it's a clavicle. Okay? When you're talking to the patient, it's the kneecap. When you're talking to a colleague, it's the patella. Use the right words for the right person. Okay? Forearm. That don't tell me nothing. Radius, ulnar, right? Leg. Leg's not helpful. Femur, tibia, fibula, what's going on? Tell me the bone that's fractured. Then tell me where it's fractured. Proximally, midshaft, distally, what location? Help me paint the picture in my mind. You're looking at the picture, I don't have it in front of me. You're telling me about it. Help me understand what's going on when you talk to me about it. There's lots of different classification systems. We'll learn Salter-Harris, you'll learn some more in ortho. Know your anatomy, know your straight lines, know your joints, know your bones. first thing is simple fracture. 2 or fewer pieces. How the heck do I have fewer than 2 pieces on a fracture? We just talked about it, right? Incomplete fractures. That's also a simple fracture. It's 1 piece. Another simple fracture is something that is 2 pieces. So if you can count 2 total pieces or less, it is a simple fracture. It's easy to fix, it's simple. Many pieces is common unit. Now, I put in here butterfly versus segmental. So that way, when you get to ortho, you can't say, I've never heard of a butterfly fragment before. What does that mean? It's a nice little triangular piece. We'll see another, yeah, it's coming up. We've got another slide, we'll kind of look at it, right? For this course, and really when you're in clinic, nobody cares about segmental or butterfly if you know common unit. Common unit means I got more than 2 pieces. It could be 3, it could be 20, right? So common unit fracture, more than 3. Simple fracture, 2 or less pieces. And that's per bone, right? So if I have 2 pieces in my tibia and 2 pieces in my fibula, those are both simple fractures. I have a simple fracture of the tibia and fibula, mid-shaft, or it's not what this picture is, I'm just explaining it, mid-shaft or whatever it's going to be. I can have a common unit fracture of my tibia and a simple fracture of my fibula. Is that right? So 2 or less, 3 or more per bone. So you can have both, just make sure you know what you're describing. Here's another one, right? Common unit, segmental. So I got 1, 2, 3, 4, 5. I'm going to draw it up here. Right? 1, 2, 3, that's 4, there's 5 there. This might be a 6 up here, right? And they're in different segments, so it'd be segmental. But really, just tell me it's common unit, I'm happy. Here's your butterfly fragment. It's this nice little triangle that kind of breaks off the bone. Why? Because it looks like a butterfly wing. It's your butterfly fragment. But really, I got 1, 2, 3 on the tibia, 1, 2, 3 on the fibula. That little fleck counts as a piece. Right? 1, 2, 3 on the humerus. So, common unit, don't get hung up on segmental versus butterfly, just know common unit, more than 2. Simple, 2 or less. Now, how do we describe it? Much like the dislocations, if the bones or the fragments are displaced, we name it for the direction of the distal segment. So option A is non-displaced. How do I know it's non-displaced? Well, if the bone wasn't fractured, I could draw a straight line down both sides, and that is lined up where it's supposed to be lined up at. It's not displaced. It is sitting where it's supposed to. There's just a fracture across it. In Bravo, I have medial displacement because the distal fragment is shifted medially from the superior fragment, or proximal fragment. How do I know medial? Look, I have a femur. Look at the way the femoral head is pointing. That's how I know it's medial. Charlie, same thing, just lateral. Lateral displacement. Okay? Delta, don't get too hung up on that. I don't need you to really just know that distracted means it's being pulled apart. It's pretty rare, because when something like a femur or something breaks like this, because of all the muscles, it usually ends up overlapping. It doesn't usually stay distracted, but that is a definition that's in the book, so we got that in there. And yes, you can technically name, look at all the words you could use, overriding with posterior and superior displacement. If I gave you all the images, you could potentially do that if you needed to, right? I need you to be able to pull out medial displacement, lateral displacement, basic directional stuff, okay? Not gonna throw a bunch of distracted and rotated lateral at you. It's just showing you how you can use all these different words to describe things based off of what you're seeing. Okay? So now the direction of the fracture is another way to describe it. Transverse, straight across. I'm going to draw because the whole line's there. Straight across is my transverse. So this, if I had the whole femur, and I can confirm those 2 pieces, would be a simple proximal transverse femur fracture. Right or left femur? Do we know? Do we have enough information? I would argue we do. Because I could finish drawing this pelvis out over here, if I use my mind's eye, and know that there's still another leg sitting over here somewhere. So that's my left, so that's the patient's right femur. I have enough information to determine that it's right, because I know the anatomy, and I know where the femoral head goes, and I know where the rest of that pelvis should be. So that is a right femur. Because if I had the whole x-ray, I'd have another leg over here, because here's where my femoral head goes in.
So I thought we were trying not to get hung up on trying to guess if we don't have an indicator.
But
So
you're
if you flip, then would the femoral head go into the pelvis? You know, if that picture was flipped, so if we don't know either way the
why
femoral
would
head.
it be flipped?
So foot was flipped.
Yeah, we just, we flip it, if we're looking anterior right now and flip it posterior, isn't the femoral head still gonna go into the pelvis?
No, this is how you're looking at the patient, right? So if I gave you just the pelvis, you would have enough to turn around and look at. I mean, just think of the anatomy, right? Even if it's flipped, the anatomy is not gonna make the pelvis kind of come over here. So you're right, I said don't get hung up on it if you don't have context clues. But we do, because we have the pelvis and we know where the femur is going. So I know that the femur is coming in here, here's my acetabulum, here's my pubic symphysis coming in over here, so the rest of my pelvis would be over here, and I would draw my other leg here, so now therefore, my left is the patient's right, that's a right femur. You can do the same thing with the shoulder if you have the thorax, because you can look at it and go, where is the rest of the body supposed to be? But if I have just an elbow, I don't have any other part of the body to do a relationship with it. It's just an elbow. I don't know. I have no thorax. The key part of this is thorax. Do I have thorax in part of the x-ray to tell me what's left or right based off of my anatomy? Yes.
How do you differentiate between an anterior and posterior view?
You don't have to, because there's no such thing as a posterior hip x-ray.
That's
So we're not covering so we don't cover what types of views a lot. Ortho will a little bit because, and let me explain. Ortho will a little bit because there are special views you can order for like ortho stuff. We don't cover a lot of views because when you order a hip x-ray, you just get the pictures, right? You order a shoulder x-ray, you order a knee x-ray, you get the pictures. The radiology department has a protocol of what they do, AP, lateral, PHS, whatever the case may be. But regardless, they're always going to present to you the images the way they are supposed to be presented, as if the patient is standing in front of you and looking at you. Right? There will be special views you will learn in ortho, but those are for special cases. But you guys don't need to learn all of the different views and what do I order when and all that stuff for the basic stuff, because every place has basic radiological protocols for basic knee, basic hip, basic foot, basic ankle. We'll talk about some of them, but it doesn't matter from the order standpoint because it's always going to be presented the way it needs to be presented to you. So I haven't really touched much of that. Yeah.
If are the images stored so you don't have to go get another X-ray, or maybe they present it a certain way, but then we found an abnormality. Like, hey, you took pictures last week. Can I go back into the? Are they digitally stored so I can go back and find more details?
So what you have here for X-ray is what you have, right? You can go back and look at it again, yes, but you can't like move it into a different position or look at it from a different angle.
Like CT has layers.
Correct. From an X-ray standpoint, you can't because it's just a solid 2D picture and that's it. Now the CT, because you have the different modes and the different things and the slices, you can do that. But from an X-ray, think of an old Polaroid camera. That's what this is. You got your Polaroid, and that's all you got. You can save it and look at it later, but you can't. You have to get the patient to do different positionings in order to give it to them. Yeah. Yeah.
When you just described that fracture, right, like you did, are you not including the relationship with fragments?
No, because what I'm describing as displacement mostly is going to be your simple fractures. Because once you say common unit, I know there's a bunch of pieces everywhere. It doesn't matter what direction they're going to me, because, I mean, it's going all different directions, right? I got no good way to describe that. I have this piece that's going medially, then I got this piece that's going laterally compared to this piece, so there's all kinds of different descriptors, which is why we just say coming and just leave it alone. Good question. Other questions before I let you go? We're gonna stop here for the day, we'll pick this back up on Monday, alright? We'll look at more pictures for those that are still having a hard time with like the left and the right, and the femurs, and the humerus, and the shoulder. We will see more of these when we get to the lower and upper